Hello, my friends. Today we will discuss clinical manifestations of liver disease. I am Samih Mikhail and I am a pathology resident. This is the Pathway channel. Please like and subscribe. I will start the clinical manifestations of liver disease by liver fibrosis. And this is degeneration and necrosis of hepatocytes and or cholangiocytes. Hepatic dysfunction actually is caused by degeneration and necrosis of epithelial cells, which are the hepatocytes and or the cholangiocytes. Replacement of liver parenchyma by fibrotic tissue and regenerative nodules, and loss of liver function. In the liver, when the inflammatory insult becomes chronic, fibrosis can then lead to apoptosis and loss of architectural integrity of the liver and cirrhosis. And cirrhosis is a stage of liver fibrosis. Many cells are involved in this process, like the stellate cells, the myofibroblasts, cytokines, Kupffer cells. And the good news is that hepatic fibrosis is reversed or stabilized at least in up to 80% of patients who are treated. Next will be the portal hypertension. And as you know that the portal vein handles all venous flow from the GI, and the portal hypertension can be pre-sinusoidal, as in the portal vein thrombosis, can be sinusoidal as in cirrhosis, and this is the main topic here today, or the post-sinusoidal, which is the hepatic vein occlusion. And actually the most common post-sinusoidal hypertension is through the cardiac diseases, most commonly the congestive heart failure. And because most nutrients arrive through the portal vein, so when this is compromised, synthetic function are also impaired, leading to hypoalbuminemia and decrease in the clotting factors. Then portosystemic shunts, which in turn compromise, portosystemic shunts will open, and so this will again compromise the metabolism, leading to high estrogen levels. The patient may have spider telangiectasia, palmar erythema, gynecomastia in men, and irregular menstruation in women. Next will be the esophageal varices. So the normal pressure of the portal tract should be from 1 to 5 millimeter mercury. More than 10, collateral portosystemic shunts will open. More than 12, then the patient is at increased risk of bleeding. The sites are all sites of the portosystemic anastomosis, which will be the esophagus, the stomach, and the rectum. And for treating this, the pressure can be reduced by pharmacological agents such as the non-selective beta-adrenergic blockers. If it is not effective, then invasive procedures can be used, most commonly putting rubber bands around the large varices. And if this is not successful, then they will do kind of stenting, which will lead to what we call the transjugular intrahepatic portosystemic shunting. Next will be the ascites, and this is the most common clinical finding in patients with portal hypertension. And this happens as we have increased hydrostatic portal venous pressure, we have hypoalbuminemia, and we have leakage of protein-enriched fluid from the surface of the liver, which will increase the intraperitoneal colloid pressure. The net effect of these forces is shrinkage of the central blood volume, which decrease renal perfusion, leading to sodium retention. So the problem here, we have sodium retention, which will lead to water retention, and as we have increased pressure in the portal tract, so this retained water will go into the extracellular spaces, which will lead to ascites and edema. So the main target or management to control ascites is to create a negative sodium balance, and this or by relieving the portal hypertension. Next, we have the spontaneous bacterial infection, which happen after a patient with ascites, and it's usually gram negative. Biochemically, you will find acidic fluid having more than 250 neutrophils or more than 500 in absence of positive blood culture. And note that cultures may be negative in up to 60% of cases, but infection should be treated empirically if symptoms and signs are present. Last thing in this diagram will be the encephalopathy, and this is metabolic disorder characterized by neuropsychiatric dysfunction. Ammonia level help exclude hepatic encephalopathy, but rarely helpful for diagnosis or monitoring. The most reliable diagnostic assessment is the electroencephalogram, which will give us triphasic waves over the frontal lobe. Another clinical manifestations of liver disease will be the hepatorenal syndrome, as we mentioned this in the ascites, and this through activation of the renin-angiotensin-aldosterone axis, which is caused by intravascular volume depletion and increased antidiuretic hormone with profound thirst. You will have hyponatremia and decrease in the potassium level, metabolic alkalosis, low urine sodium and high urine potassium, and high urine osmolality. You can measure the urea level, the creatinine level, but they are not reliable indicators in case of hepatorenal syndrome, because urea production by liver is often decreased in advanced liver disease. And also creatinine production by muscle is reduced in cirrhosis. So this may be a bit misleading because you will have low plasma creatinine concentration. Creatinine clearance will be again misleading. We have two types. Type 1, the classic type, which is the rapid decline in renal function. Type 2 is the slowly progressive decline in renal function. Last clinical manifestation, we will mention the jaundice. And just a few points about jaundice. So it's apparent clinically when the plasma bilirubin reaches 2 to 3 milligram per deciliter. It's most specific clinical manifestation of the hepatobiliary dysfunction, and it's characterized by gray-colored stools and orange-brown urine. So just to remember, 2 to 3 milligrams per deciliter to have apparent jaundice. Number 2, hepatobiliary dysfunction, and remember gray-colored stools and orange-brown urine. Thank you so much. Please like and subscribe to receive more videos from the Pathway channel.